Hello class! Today let us discuss glycemic control in pregnancy. Pregnancy is often described as a diabetogenic state, meaning that metabolic and hormonal changes during pregnancy promote increased blood glucose levels. Insulin requirements do not remain constant throughout pregnancy. Instead, they fluctuate significantly due to placental hormone production and the increasing nutritional demands of the developing fetus. The primary goal of glycemic management during pregnancy is to maintain euglycemia, normal blood glucose levels, in order to prevent complications for both the mother and fetus. Poor glycemic control increases the risk of complications such as macrosomia, large baby, neonatal hypoglycemia, preeclampsia, cesarean birth, and birth trauma. The placenta plays a central role in altering maternal glucose metabolism. Placental hormones such as human placental lactogen, HPL, cortisol, progesterone, and estrogen create a state of insulin resistance. This ensures that sufficient glucose remains in the maternal bloodstream to provide a continuous supply of nutrients to the fetus. As pregnancy progresses and placental hormone production increases, the mother's body becomes progressively less responsive to insulin, requiring adjustments in insulin dosage to maintain optimal glucose control. The first trimester, weeks 1 to 13. During the first trimester, insulin requirements often decrease because maternal insulin sensitivity increases. In early pregnancy, the developing fetus requires glucose for rapid organogenesis, formation of organs, and hormonal changes initially enhance insulin effectiveness. As a result, maternal blood glucose levels may drop more easily, increasing the risk for maternal hypoglycemia. Additionally, many pregnant women experience nausea and vomiting, morning sickness, which can reduce food intake and further contribute to low blood glucose levels. Because of this, insulin doses may need to be reduced during early pregnancy. Nurses should closely monitor patients for symptoms of hypoglycemia, such as dizziness, sweating, shakiness, confusion, and fatigue. Patient education should emphasize the importance of frequent small meals, adequate carbohydrate intake, and regular blood glucose monitoring to maintain stable glucose levels. The second trimester, weeks 14 to 26. During the second trimester, insulin requirements begin to increase as pregnancy progresses. The placenta grows significantly during this period and produces increasing amounts of human placental lactogen, HPL, which acts as an insulin antagonist. HPL decreases maternal insulin sensitivity, resulting in higher blood glucose levels. This physiological insulin resistance allows more glucose to remain in the bloodstream so that it can be transferred to the fetus for growth and development. As insulin resistance increases, insulin dosages often need to be adjusted upward to maintain blood glucose within the recommended target range. This period represents the beginning of the strong diabetogenic effect of pregnancy. Nurses should emphasize regular glucose monitoring, adherence to dietary recommendations, and collaboration with healthcare providers to adjust insulin therapy appropriately.